Nick Majerison here, and welcome to Top Med Talk. And this is part 2 of our special series about POPS, proactive care for older people undergoing surgery. We're coming, of course, from Guy's and St Thomas's Hospital, where you've been hearing Desiree Chappell having a conversation with her guest, Dr. Jugdeep Dhesi, and Dr. Judith Partridge, Consultant Geriatricians at Guy's and St Thomas's Hospital. As you'll now hear, the conversation widens out a bit, and Desiree continues speaking to some of the people who work on the POPS programme at Guy's and St Thomas's Hospital in central London. This is part 2 in a series on POPS, and your experience of listening to this will be greatly enhanced if you ever listen to part 1.
Top Med Talk.
All right, we are at Guy's Hospital down in central London, and we have another special guest with us here discussing the POPS program at Guy's, and it is Magda Sbai, and she is a trainee doctor in gerontology. Thank you so much for joining us. So I guess we'll just start off by asking how you got involved with this program and your interest in gerontology and how you've come into this program here at Guy's.
Okay, so throughout my training, there's various encounters that I've had with perioperative medicine, mostly through orthogeriatrics, which is reasonably well established in the UK. There aren't that many. It's a developing part of the curriculum for geriatric registrars, and that the higher grid in our curriculum for perioperative medicine has only recently been established. And I had the opportunity of doing a 6-month job in another trust in a less developed service, and I liked the caseload. So there's lots of geriatric issues as well as acute general internal medicine issues, and the idea of having continuity through a patient's care, so seeing them preoperatively, trying to optimize them for surgery, and then following them up and case managing them up until discharge. And I wanted to come into a service that was more developed because I thought that this is potentially something I'd be interested in as a career. So I was lucky enough to work with somebody who'd been a fellow here previously as my boss, asked a bit more information, saw that the job was being advertised, read a bit more about the service. It sounded like something that I would get a lot out of and would be well suited to the skills that I have and the type of medicine that I'm interested in, and applied for the job, and as they say, the rest is history.
So what has your experience been here so far, working as a trainee?
It's been amazing, actually. So there's a real focus on collaborative working here and shared decision making. It's been great as an experience being exposed to so many different surgical specialities, so from vascular to general surgery to urology to some of the more complex surgeries that I haven't had experience of before, things like max fax and ENT surgery. And being able to see CGA working, so comprehensive geriatric assessment, which is well established and good evidence base in general geriatrics being used in the perioperative setting, has been a great experience because it does work, and I've seen that firsthand, and it does pick up all the issues that you can then target your interventions to. And the thing that I found most interesting is the shared decision making and talking with surgeons and anaesthetists and patients about what is the best option for them based on all the information we've gathered. And I've been surprised coming into it, some of the patients that we can get through surgery and have good outcomes, but also equally surprised about the patients that we have decided for them the best option isn't surgery, and how do we optimise symptoms and quality of life for them.
One conversation I think that we have on Top Med Talk is about shared decision making and working as a team to do that, and then actually having the conversation with the patient and how that can be rather difficult. How is communication with your specialty, so the elderly population, different, than what you have dealt with in the past?
So I think it's not different at all, actually. I think that what is different in the POP service, and I think is different in geriatric care, is that we're not afraid of talking to the patient. So many other specialities will feel that this patient is old, they may not understand the risks and benefits, and don't discuss it with them frankly. And actually my experience is, even with patients with some degree of cognitive impairment, if you can take the time, explain it to them in a way that they can absorb the information, and that might mean several times meeting them and going through the issues, that actually they really appreciate it, and they can come to a decision that is best for them, because at the end of the day they're going to have to live with the implications of surgery or not having surgery, and they should be entitled to be involved in that discussion. So actually I think there aren't that many issues regarding communication, and the issues are related to medical professionals not having that conversation in the first place.
So very true. It is a difficult conversation. And if you're not prepared and trained for that, I think that's when it becomes even more difficult. How has it been working with some of your other specialty colleagues, so anesthesia, surgeons, and also nursing, and bringing them into the conversation, other allied health professionals?
For me, it's been really interesting and enlightening, actually. I think if you come at it from the angle that there are parts that you won't understand and there are parts that you will be an expert in, and that if you have an open and honest conversation about, I don't think that this should happen, or I think this should happen, what do you think? Or asking when you don't understand, what are the surgical procedures that can be done for this patient, or what are the anaesthetic options that are possible, then actually the discussions aren't difficult. It just requires almost a bit of humility and saying, I don't understand this, would you explain it to me? And I think that's what's important in shared decision making. There is not one specialty, I think, that can do perioperative medicine alone. I do think we need anaesthetists, physicians and surgeons to work together to come to the best outcome.
Thank you so much for sitting down with us. I really do appreciate it. It's enlightening conversation, of course. So we will catch you later. Thanks.
Top Med Talk.
Jugdeep is going to introduce two very special guests here at Guy's. Jugdeep, who do we have here?
So we have Jason Cross, who's our advanced nurse practitioner and the nursing lead for the POPS team. And we have Claire Gallagher, who is one of our Band 7 clinical nurse specialists working within the team. So they do lots and lots of our work within the team, and we couldn't function without them. So Jason's been doing a lot of work around the things that I was mentioning about developing the allied health professionals kind of program, with developing a curriculum, a competency framework and e-learning modules to support that. And Claire's been doing lots of work clinically with us, both pre-operatively around the assessment, optimization, delivery of CGA, but really kind of works very closely with the patients on the ward, both in the emergency and the elective patients coming through. So I don't know, Jason, if you want to talk about how we are developing the nursing programme within POPS.
What a fantastic introduction. So we struck on the idea of developing a nursing programme after we'd had a couple of nurses from the ward join the team and started thinking about how we upskill members of the nursing staff, and thinking whether we could actually expand it to an educational programme that anybody could jump in on, learn about perioperative medicine with a nursing focus. So using our experience, using our current nursing team, and also scoping some of our ward colleagues as well, we've been putting together a competency framework, working closely with Health Education England to ensure that we're actually doing it correctly and properly, and then linking with the BGS, utilising some of our other curricula for junior doctors and more senior SPRs to actually create a curricula that will hopefully support the Band 6 or Band 5 or 6 nurse to maybe into an advanced nurse practitioner within perioperative care.
You're working with not only the nurses that are involved in the geriatric side, but across all the different specialties, right? And how has that been to work as a team as part of the nursing group?
It was evident when I was developing or looking at the competency framework early on, not just to think that just because I do something well or we're doing something well, that we should just be saying that's the way we should do it. So it was really interesting for me to actually be talking to nurses outside the geriatric kind of nursing arena, actually talking to junior kind of developing nurses across surgical specialties to look at ways of clinical supervision and integrating that kind of ward-based ad hoc kind of learning and support throughout the whole of the competency framework. Things like clinical supervision. My concern was you become a specialist nurse, or you get a title of specialist nurse, but people come into those roles without a lot of specialist knowledge. They obtain a title of specialist nurse without really understanding the pathways that they are supporting or the care that they are promoting. So it was very important to me that within the competency framework we actually factored in some of that clinical supervision, the background foundation skills to a lot of the advanced nurse practitioner the kind of focus education early on, so when they did step up, they actually had the foundation of skills that they needed.
Fantastic. Well, Claire, being on kind of the clinical side and working with patients, how have you realized this making a difference in your practice and then for patients?
Just leading on from what Jason was speaking about just there with clinical supervision for kind of more junior members of the team, I started as a Band 6 patient pathway coordinator in the POPS team, and had come straight from the wards as a staff nurse, and have found that my skills have greatly increased, and my whole understanding of the perioperative pathway and what medical liaison services can add and do add to the geriatric patient on the ward is just improved like tenfold. Jason provides my clinical supervision, and I've worked really closely with him, and have actually moved from working more as a pathway coordinator to working more directly and slightly more independently on the wards as a clinical nurse specialist, and completely agree with what he says is that you get given a title of clinical nurse specialist with not much knowledge of that of the clinical pathways in that area.
I think it's worth supplementing that, and what we want to do with any kind of educational kind of program or competency framework is highlight you just don't need nursing support, you don't need nursing guidance, and my professional kind of practice and my clinical skill acquisition has been done in partnership with Jugdeep, the other consultants. I have 2 line managers, I have a nursing line manager, and I have a clinical supervisor in Jugdeep, and that's what we want to support and advocate with, not only just with perioperative pathway kind of education, but also for advanced nurse practitioner education across the board. I think it's something that's probably lacking, and something as advanced nurse practice becomes more prevalent within the health service probably is needed as well.
In the US, if you obtain an advanced level nursing degree, advanced practice nursing degree, you can focus in geriatrics or other specialties. Can you do that here?
It's usually the way. It's usually you've kind of followed your nose into a particular area of nursing that you like, and then you become a clinical nurse specialist, so quite focused. And then the advanced nurse practitioner pathway is a lot broader. It has an emphasis on prescribing and comprehensive assessment. So the avenues open slightly. The clinical nurse specialist tends to be quite single organ or specialist area focus, whereas the advanced nurse practitioner has more flexibility to change career paths.
So Claire, you said you were on the wards before. Were you working with the elderly population there and geriatric population there, or is this something that you've just kind of changed since you've been involved with the POPS model?
I was based on surgical wards before I came to this team, and most surgical wards have a very high population of elderly patients, especially in the hospital that I was working in and the unit I was working in had quite a high population of multimorbid, maybe even slightly younger patients, but definitely multimorbid with the beginnings of geriatric syndromes. So I feel that I was quite prepared for the population that we see, but probably didn't realise the potential of POPS, the medical liaison service, that they could have added to my care for those patients.
I was just wanting to know kind of the difference that you saw and when you're taking care of patients then versus taking care of patients now with this model.
I have a much more holistic look at the patients that I'm caring for now. Using the CGA, the Comprehensive Geriatric Assessment of the Ward, has, even though I do think that it is very similar to the Roper, Logan and Tierney that were taught in university, it's enabled me to see a lot more rounded view of the patients and really focus towards functional trajectories and where they're going to be after they leave hospital, not just focusing on what their blood pressure is on the day of surgery, on the day after surgery, that sort of thing, but more so looking at them in the future in the community with their families, and how we can successfully manage them and their independence, or maintain their independence pre and post surgery.
Just wanted to add to kind of what Claire's kind of saying, because Claire's kind of very modest, as is most of our team. So, I think really just to kind of describe what Claire might do when she goes up on her regular ward rounds is that she'll come back to talk to me about the patients, and what she will have done already is gone and assessed the patient post-operative. For example, this is post-operatively. So she will have assessed the patient, will have examined the patient independently, will have reviewed drugs, considered starting. She's working on her nurse prescribing course now, so she'll be an autonomous prescriber hopefully within the next year or so. She will have reviewed ECGs, chest x-rays, and then come back and present that patient in a really concise, succinct, articulate manner back to me, such that often I just need to then add a couple of things to the plan that she already has in place. And I think the other real value, which is constantly fed back to me when I'm talking to senior nurses from around the hospital, is how Claire and the team are changing the way that the rest of the nursing workforce integrate, talk to each other, the language that they use when they're reviewing older patients, and upskilling them as well in the assessment and management of older patients. So I think, the added benefit is not only to that individual patient, but also the added benefits across the workforce in the hospital.
Claire, Jason, team anaesthesia, are any drugs that we tend to prescribe that you really wish we didn't? Oh, I know you've probably educated out of everyone here, but take a broader view. What are the biggest enemies?
Tramadol. Tramadol's horrible. It's just evil. Cyclizine. Its impact and exacerbates delirium. And Claire's just whispered a Danceton as well.
We give every single patient.
You give every single. They're just not nice to our older patients. But there may be very good reasons why you're prescribing certain medications, and it's only by us having this collaborative kind of discussion and that we learn from each other. We don't know every indication for every medication that's given through an anaesthetic, and there may be a very good reason, no matter what of the side effects. So it's the list. That's our little bugbear, but maybe there's stuff we prescribe that you don't like either.
So give us 3 alternatives then.
Some of the simple analgesics are under prescribed, things like paracetamol. I know that we are very much focused on kidney function, and obviously in a patient that's renally impaired, then we need to avoid non-steroidal anti-inflammatories, but there are benefits. I think I work predominantly with GI patients, so looking at some antiemetics that could also help other gut stimulation like metoclopramide. There's always an alternative, and you just need to come and ask us.
I think that's the key to all this. We all need to talk to one another and see what works best as teams and what's best for the patient. So, guys, thank you so much for sitting down with us. I know it was a pop question if you'd come and join us, but we appreciate it and look forward to seeing what happens with the POPS program going forward. Thanks so much.
Top Med Talk.
Thanks for downloading Top Med Talk. Don't forget, this is part 2 in the series that we're producing at the moment about POPS, proactive care for older people undergoing surgery. We did it at the Guy's and St Thomas's Hospital in central London, and your experience of this podcast will be greatly enhanced if you listen to episode 1. If you have any difficulty finding that, why not go to topmedtalk.com. That's topmedtalk.com.